Hi, everyone. Thanks for joining us today. I'm so pleased for us to have Dr. Alice Lamb with us here today from the Massachusetts General Hospital. She's going to be speaking with us about seizures and epilepsy in older adults. And we'll get started here in just a moment. Remember, you can type your questions into the question panel at any time during the webinar. Thanks to you all for joining today. I'm just going to share a little bit about Dr. Lamb with you all. So Dr. Lamb obtained her MD and her PhD degrees from the University of Michigan Medical School. She trained in neurology at the Partners Neurology Residency Program, which combined training at Mass General Hospital and Brigham and Women's Hospital here in Boston. And she obtained her subspecialty training in clinical neurophysiology and epilepsy at the Massachusetts General Hospital. Dr. Lamb is currently an epileptologist and clinical neurophysiologist at MGH and an assistant professor of neurology at Harvard Medical School. Her translational research program focuses on the intersection between epilepsy and the neurodegenerative diseases. As a physician, she sees patients in both the epilepsy clinic as well as the memory disorders clinic at MGH. She also co-runs a bi-monthly support group at MGH for adults with epilepsy in partnership with our affiliate, the Epilepsy Foundation of New England. So Alice, thank you so much for being here today. I'm going to turn things over to you.
Thanks, Elaine, for that really kind introduction. It's a real pleasure, actually, to get the chance to speak with you all today and to share what I think is some really important information about epilepsy in older adults. This is a population that, for some reason we tend to forget about when we think about the kinds of people that epilepsy can affect. But what I hope to show you today is how common epilepsy actually is in older adults, and to emphasize how important it is that we really strive to include this population when we think about the kinds of epilepsy resources that we're providing to our communities. So I want to thank Elaine for really doing most of the work in putting this talk together and for helping to organize this webinar. So let's get started. As I said, epilepsy is really common in older adults. There are approximately 1 million older adults living with active epilepsy in the United States. And in approximately 50% of these older adults, the seizures that occur, basically the cause is unknown for these folks. Just to remind you all, when we talk about epilepsy, we're talking about a risk for recurrent seizures that a person might have. But when we say someone has epilepsy, it tells us nothing about what the cause of their epilepsy is, and it tells us nothing about what the prognosis of their epilepsy is. As I'm sure you all know, there's many different types of epilepsies, and there's a huge spectrum of impact that epilepsy can have on someone's life, ranging from someone who can be seizure-free and function completely normally as long as they take their seizure medications, to someone who may be on multiple seizure medications and experiencing side effects from those medications and maybe still continuing to have seizures. What I've said here isn't specific to older adults. It applies to really anyone with epilepsy. But again, it's important to remember to include older adults when we think about these things. So let's just talk about epilepsy in older adults. As I said, in the US, there's about a million older adults, that's people over the age of 55, who report active epilepsy. And, the incidence of seizures and epilepsy actually increases as people get older. And each year, there's over 50,000 new cases of epilepsy in people over the age of 60. And as I said before, in 1 out of 2 older adults, the cause of their epilepsy is actually unknown. This is an outline of what I'd like to talk about today. First, we'll talk about the causes, evaluation, and treatment of seizures in older adults. And then we'll focus on the seizure types and the risks of these different types of seizures, and particularly as it pertains to older adults. And then finally, we'll talk about some public awareness things on epilepsy in older adults and what you guys can do to help raise public awareness about this issue. Okay, so let's start with the causes, evaluation, and treatment options of seizures. So the things that cause seizures in older adults are very different than the kinds of things that cause seizures in younger people. So really the main three things that I think about as the causes of seizures in older adults are stroke, brain tumors, neurodegenerative diseases. But there's also a number of other things that can cause seizures in older adults. And some of those things can be metabolic disorders, for example, abnormalities in blood glucose levels in someone who may be like a diabetic, for instance. Alcohol withdrawal can certainly be a cause of seizures in older adults. And then things like infection and head trauma are also causes of seizures in older adults. But let's just get a sense of, the risk factors and how much these different causes can sort of influence the risk that someone might develop epilepsy as an older adult. So as I mentioned, the biggest risk factor for epilepsy in older adults is stroke. And you can see that someone who's had a stroke, an older adult who's had a stroke, has a 20-fold higher chance of developing seizures than, another older adult who's never had a stroke. Similarly with dementia, someone with dementia has a 5 to 10-fold greater risk of developing seizures compared to, a healthy older adult without dementia. And you can see, again, sort of the risks of all these different factors here. But again, just pointing out stroke and dementia are really, really big risk factors in this older population. So now that we know who's at risk for developing seizures as an older adult, how do we go about recognizing the signs of seizures in older people? So as you know, one of the big misconceptions in the public is that, seizures have to be these big events where someone falls to the ground and has a big convulsion, foaming at the mouth and things like that. But as I'm sure you all know, the signs and symptoms of seizures can be much more subtle than that. And this is particularly the case in older adults. I think this is one of the reasons that seizures can easily go unidentified in this population as well. So, listed on this slide here is just a number of symptoms that older people might experience with seizures. And you can see that a lot of these things are fairly subtle. It could be sort of staring off into space for a few minutes and being unresponsive, or feeling disoriented, just a little confused. It might present as spells of dizziness, maybe as hallucinations where someone may be seeing, flashing lights, or they may be hearing, noises that aren't there. I won't go through this entire list, but as you look at it, you can see that, a lot of these problems a lot of these symptoms are fairly subtle, and you can probably attribute them to a number of other things, even if not seizure. So, now that you've seen those other symptoms, you can see that they can certainly occur with seizures, but as you imagine, these symptoms could also be caused by a lot of other medical conditions. For instance, if someone's, passing out or losing consciousness, they might just think that they fainted. If someone is feeling kind of dizzy, confused, sometimes that can occur when someone's blood sugar has gone too low. Transient ischemic attacks, those are another word for those is a mini stroke, where the blood flow to someone's brain has been cut off for a short amount of time. That can present with some of the symptoms on the previous slide. And I won't go through all of these, but you can see that there's a lot of other conditions that we have to think about when we're thinking about whether or not someone has had a seizure, or what else it could be. So now that we know what the symptoms of seizures can be in older adults, and now that we also are thinking about what other medical conditions can mimic seizures, now we can talk about how an epilepsy doctor like myself might go about evaluating someone for seizures. So really the most important thing for me is to get a really good medical history and a really good description of the event. So, it's important to note that the person who's had the seizure or who's had these symptoms may have experienced this event very differently than what people around them observed them to be doing at the same time. So while I always ask the person who had the symptoms, what they experienced, it's just as important, sometimes can be even more important to ask the people around them. So the kinds of questions I'll ask, what was the person doing right before the event happened? What symptoms did they experience? Did they smell something funny, taste something funny? Did they feel confused? What happened to their arms and legs? What were they doing with their arms and legs? How long did these symptoms last? Did the person remember the event afterwards, or were they really confused afterwards? And then also, was this the first time this person's ever experienced these symptoms? Or, maybe have they been having repeated episodes of these same symptoms, again, which would make you think, seizure might be a lot more likely. And was there anything they could think of that may have triggered the symptoms? For example, did they have a change in their medications, or were they sick at the time, or had they been drinking more alcohol than usual, things like that. And so a lot of the time with, just this information, I might have a pretty good sense of whether or not a person has had a seizure just based on this description of the event. Now, after I get a description of the event, it's important to do some other tests. And you can see here, we do a medical and neurological exam. We'll check some blood work. We'll usually get an electroencephalogram and EEG to look at someone's brainwaves, as well as an MRI scan to look at the structure of their brain. And the goal of these tests, there's multiple goals here. One is to look for an underlying cause for the seizure. For example, did the person have a stroke in the past? Or, are there signs of a brain tumor on their brain imaging? Or, in terms of blood work, were their blood glucose levels too low, or was their sodium level too low? Things like that. Because obviously if there's an underlying cause for the seizure, then you want to address that cause. But also these tests can help us determine whether or not, this person may be at risk for recurrent seizures. So if we see an abnormality on the EEG, for example, an epileptiform discharge, that might tell us that this person is at risk for recurrent seizures and that we would want to treat them with a seizure medication. And then finally, you see these two tests at the bottom here, looking at cardiovascular testing. This might be looking at someone's heart rhythm to make sure they have a regular rhythm, or to look at an echocardiogram, which allows us to look at the structure of the heart to make sure, things like the valves are working normally and that the heart's pumping normally. And then there's autonomic testing. That is also called tilt table testing, and that can give us a sense of whether someone may be susceptible to spells of passing out rather than seizures per se. And so these tests can, again, help us to rule out potential seizure mimics, such as, a heart rhythm problem, or whether someone might be just be passing out instead of having had a seizure. Now, once we've done this evaluation for seizures and we think that someone has epilepsy, there's a number of different available treatments for epilepsy. We have anti-seizure medications, and as you know, this is the first line of therapy to control seizures. We'll talk about different factors that might determine the drug choice, but it's important to know that in 2 out of 3 people with epilepsy, we can, make them seizure-free just with anti-seizure medications. But for 1 out of those 3 people, seizure medications may not be able to fully control someone's seizures. And so we might consider other options such as epilepsy surgery or neuromodulation or dietary therapy and other things like that. Now this slide, I could have shown you this slide for pretty much, anyone who has epilepsy, ranging from kids all the way up to older adults. But really the point that it's trying to make is that, the treatment options that we have to control seizures in older adults are really no different than they are in younger individuals. But there are some things that we have to think about a little differently in older adults. So we need to make some of these treatment decisions based on, the impact of seizures and how these treatments might affect the person's quality of life. And in older adults in particular, it's really important to think about comorbid disease, meaning what other medical conditions does this person have, and how might that affect what medications you can use to treat their seizures, and how might it affect how epilepsy might affect this person. So we'll talk about some of those things in a little bit. So to start with anti-seizure medicines, the types of anti-seizure medicines that are recommended in older adults, you can see here. These are medicines that have been found to be effective for seizures, to control seizures in older adults, as well as they tend to be better tolerated in older adults. And these can include lamotrigine, levetiracetam, gabapentin, oxcarbazepine, and topiramate. There's several medications I've listed here, but maybe the most important thing is to say that in general, the newer seizure medications tend to be much better tolerated in older adults compared to the older seizure medicines, such as like Dilantin, phenytoin, phenobarbital, and some of these other medications. The older medications tend to have more side effects, and they also tend to have more drug-drug interactions compared to the newer medications that are available. One of the mantras in treating older adults with anti-seizure medications is that you should start low and go slow. So you start at a low dose and you sort of increase that dose slowly so that you can monitor both for how effective that medication is going to be in terms of preventing seizures, as well as whether or not that medication is going to cause any side effects for this older person. Often extended release formulations of these medications can be really helpful, not only for adherence to medications. These extended release formulas are often once a day pills, and so it makes it a lot easier for someone to remember to take their medication if it's only once a day compared to 2 or 3 times a day for some of the immediate release formulations. And also these extended release formulations can be helpful in terms of reducing side effects. So often side effects of dizziness and fatigue, sometimes those can be drastically improved when you switch to an extended release formulation. So that can be really helpful in older adults. Some risks and challenges that are really specific to treating older adults with anti-seizure medications. These can include side effects from the medication. So older folks tend to be a bit more susceptible to side effects from the medication, sometimes because they're on a number of other medications already. So a lot of seizure medications, one of the side effects can be dizziness. And if someone is on a number of other medications that are also causing dizziness, then they might be a lot more symptomatic from that standpoint. Another issue in older adults is that their people's metabolism changes as we get older. And since a lot of medications are metabolized through the liver, older folks tend to metabolize drugs more slowly than younger people. And so they often may not need as high a dose of medications as someone who's a bit younger. But it's important to recognize that can happen. And then finally, we often use drug level measurements to determine whether someone's taking a medication in a range that's within what we consider a therapeutic range. But it's important to note that these drug level ranges that we have were really developed in younger people. And so in older people, the therapeutic window might be a lot more narrow than in a younger person, so that they might develop side effects at much lower doses. And again, that you may not need as high of a dose in order to be able to treat their epilepsy. So let's move on and talk about types of seizures and sort of the risks of these different seizure types, particularly as they pertain to older adults. So you've probably seen this schematic before. I think you're all aware that we classify seizures in different ways. And this most recent classification is based on how much of the brain is involved when a seizure starts. So I think about seizures as being electrical storms in the brain. And for focal onset seizures here on the left here, you can see that these are seizures where the electrical storms initially only involve a small part of the brain when they start. That's in contrast to generalized onset seizures here, where the electrical storms involve the entire brain all at once at the beginning of the storm. And then there's what we call unknown onset, and that's where in some folks we may not have enough information to know whether or not their seizures are focal or generalized in onset. Now, with focal seizures, people may or may not be aware of what's going around them while the seizure is happening. So we split focal onset seizures into, focal aware seizures and focal impaired awareness seizures, depending on whether or not someone's thinking is impaired or not during the seizure. Generalized onset seizures pretty much always involve impaired awareness. And both focal and generalized seizures can have motor symptoms. That might be something like shaking or stiffening of part or all of the body. But they can also involve symptoms that are non-motor symptoms. For instance, smelling a funny smell or tasting a funny taste that's not there, or even just a feeling of dizziness or a feeling of of vertigo, things like that. So that's in general how we now classify seizure types. In older adults, the most common type of seizure is the focal impaired awareness seizure. So over 50% of seizures in older adults are this focal impaired awareness type. But they can still have these other types of seizures. These focal impaired awareness seizures can turn into generalized tonic-clonic seizures. They can also have focal aware seizures. But this is really important to note in the older adult population. There are challenges with these focal seizures. First, these symptoms that go along with focal seizures may not be recognized as seizures. As I showed you in a couple slides ago, these symptoms can be pretty subtle, and they can seem kind of non-specific. And older adults, they may notice these symptoms, but they may misinterpret these symptoms as being just, I'm getting older, and maybe this has to do with the fact that I'm getting older, and maybe this happens to everybody as they get older. So they might misinterpret these symptoms as just effects of aging and not seek treatment because of that. Or they might interpret these symptoms as being linked to other medical disorders. I felt kind of dizzy. Maybe that was because my blood sugar was kind of low. Or I felt kind of dizzy. Maybe that's because I'm taking these blood pressure medications, and maybe it's just a side effect of my blood pressure medications, things like that. And as I said, over 50% of these focal seizures are these focal impaired awareness seizures. So, someone might be experiencing these symptoms, but they may actually not be aware that they're having these symptoms unless there's someone else who is there to witness the event and to tell them, you spaced out there for a few minutes. Or they may be aware, but they may actually forget the episode. Sometimes people will forget that they had a seizure, and that's part of the seizure symptoms. And so they may not be able to tell people about these symptoms if they forget about them. So these are all challenges we deal with focal seizures. And, it's not uncommon that these symptoms can go undiagnosed in a lot of people for a long time. And often what happens is they may go undiagnosed for a while, and it's not until the person presents with, full-blown convulsion that then, after we sort of talk to them about other symptoms, it sort of comes up like, actually, I've been having these smaller spells. I didn't make anything of them until now. And so that's often how these things can present. But it makes it really important for us to be able to recognize the different symptoms that can come with focal seizures, just so that we're thinking about them in older people. There's also challenges with these GTC, or generalized tonic-clonic seizures. Again, these convulsions that people might have as older adults. Older people can be a lot more frail than someone who's younger, and so they may be a lot more susceptible to injury from falls. They might suffer from bone fractures or from head injuries from these falls. They can also have muscle and soft tissue injury from these big convulsions. And it can take older people a lot longer to recover from a generalized convulsion compared to someone who's a lot younger. Often people are hospitalized in the setting of these generalized convulsions, and there's risks for hospitalization as well. And then there's safety issues, and these apply to not just older people, but really anyone with epilepsy who's having these generalized convulsions, is that they can have burns or scalds if they're, for instance, cooking while they're having a seizure, and drowning, obviously, is something that we also worry about for people who might be swimming. Just to touch on some other considerations in older adults, it turns out that non-epileptic seizures or non-epileptic spells are a frequent problem in older adults as well. They can occur just as frequently as in younger people. So it's important to know that, again, as part of our evaluation for seizures and other things that might present similarly to seizures. And, I touched on this a little before, but these seizures in older people, they tend to have an onset in the frontal or parietal lobe. And that means that the symptoms that are associated with these seizures can be a lot more focal, a lot more subtle than other types of seizures that we commonly think about. The postictal state, as you know, it's the period after a seizure where someone might be confused or not fully responsive, not fully back to themselves. That can be prolonged. In older adults, it just takes them a longer time to recover from the seizure. And in some people, it can last, even longer than 24 hours. It's a lot longer than we normally think of in younger people. And, after just a 1-minute seizure, for example, an older adult may have a prolonged state of confusion, a temporary paralysis, or even falls, and this can persist for several days after just a 1-minute seizure. So again, older people tend to be a bit more medically frail than younger people, and these seizures can affect them in much more profound ways than in younger folks. And so you can see seizures really can have a really significant impact on the quality of life for older adults. Okay, so let's finish by just talking about some public awareness issues, especially as it pertains to epilepsy in older adults. There are a lot of public misperceptions in epilepsy, and so it's really important that we raise awareness and understanding of epilepsy. As you know, these misperceptions can impact not only whether someone might seek care for their epilepsy, but also how they might be treated when others find out that they have epilepsy. So it's really important that we continue to raise awareness and understanding. And again, thank you for all of the work that you all do in helping to address these issues. As you know, there's a lot of misperceptions. One may be that epilepsy is associated with mental deficiencies, and this can lead to denial on the part of someone who may be having seizures that they actually have epilepsy, whether they actually have epilepsy or not. Or it may lead to people kind of ignoring seizure warning signs or symptoms because they don't want to be diagnosed as having epilepsy. They don't want to be thought of as someone who has epilepsy. And again, there's a lot of stigma that our society still has about epilepsy. Again, beliefs that epilepsy may cause aggressive behavior, that epilepsy causes an undue burden on family and on society, that epilepsy makes someone less able than someone without epilepsy. And again, a lot of people think that epilepsy is mainly a disease of the young, but I hope I've shown you today that this is really not just a disease of the young, and that older adults are very significantly affected by epilepsy as well. And finally, there's a stigma that epilepsy will unnecessarily limit someone's independence. So these are all perceptions that we're trying to erase and trying to show people that people with epilepsy can live normal lives and can be independent and highly functioning. So what can you do to share this information with your communities? What are the important things? What are the important things to take away from this talk? Again, I think it's really important to recognize that epilepsy is highly prevalent in older adults. Again, to bring back that number, 1 million adults in the United States, 1 million people over the age of 55 have epilepsy. So it's important to identify seizures early in this population, as again, we talked about the different ways that seizures can impact an older person and their quality of life. And it's important to recognize that there's special considerations in this population with regards to how we evaluate them, what things can cause seizures, and how we treat these older adults in terms of what other medical problems they might have and what other medications they might be taking at the same time. Managing risks for physical and emotional health is very important as well. And really what we want to do is balance treatment and quality of life. We're always trying to maximize the quality of someone's life, and sometimes that is a give and take in terms of controlling seizures, but also managing medication side effects, things like that. I think a final thing that's really important to think about is caregiver stress. And so an older person, when you think about an older person in the community, they may be living by themselves, or they may be living with a spouse who may also be, also likely older and has a number of their own medical problems. And, they may just be getting by in terms of, functioning at home. But when you add another disease like epilepsy on top of this, this can add a lot to caregiver stress, and it can really make things challenging for someone who's older to remain living at home independently. So it's really important that we recognize this and that we ensure that proper supports are in place. And this is something that I think we can be thinking about in terms of what kinds of programs we offer in the community, and making sure that some of these programs target, or make sure that they're inclusive of older adults and, the different kinds of issues that these folks might have dealing with epilepsy compared to someone who's a lot younger. So with that, I think we'll stop here and we'll take some questions.
At this time, I'd like to say thank you very, very much, Alice, for joining us today. We appreciate your time and your sharing your expertise with us. And thanks to everyone who joined in for paying attention and making the time to log on today.